my name is Eileen Davidson, also known as Chronic Eileen, and with me today for the 2023 TalkOverRA campaign is Dr. Jennifer Barton, an academic rheumatologist from Portland, Oregon, correct? Yes. And TalkOverRA is a campaign to help those with rheumatoid arthritis improve their communications with their rheumatologist around remission, but that's sometimes an unclear concept for many, myself included in the early years of my diagnosis. For the TalkOverRA campaign this year, I wanted to interview as many rheumatologists from around the world on what remission with rheumatoid arthritis is. After attending the Canadian, American, and European scientific conferences, I really like learning from experts in their field and from around the globe. I hope you learned something from this project you can use in your journey with rheumatoid arthritis or even other types of inflammatory arthritis, wherever you are in the world. Dr. Barton is giving us the US perspective on this topic. Now, don't forget to check out the other videos, especially the patient perspective video on what remission is to us. There will be a link in the description for that video. Now, let's dive in. Thank you so much for joining me today for this discussion, Dr. Barton. I'm going to start off by asking you, what is remission?
Well, thank you so much for reaching out and taking the time. I think in my mind, philosophically, it is really having no painful or swollen joints, and low measures of inflammation systemically, and for people to be able to function as though they didn't have rheumatoid arthritis. I think that would be my ideal definition of remission. I know there are certain, academic and scholarly definitions of remission, but that is sort of the one that I think of.
Now, is there a one-size-fits-all for what remission is?
I think that it is very variable. I think a lot of things with regard to rheumatoid arthritis and living with rheumatoid arthritis are very individualized. And I do think it, for each patient, it probably does mean something different. And perhaps for each rheumatologist, maybe they have a different definition as well. But I think as low disease activity as possible, as low impact of the condition on someone's ability to live and work and participate in life is what I would consider. But I think for every person that is going to be different.
Indeed it is. That's why I'm doing a series of interviews. Now, can you tell by someone's blood work if they are in remission?
No.
That's interesting. What are some factors in our blood work that patients can tell if they're doing good or if they're not doing good?
Yeah, so there are two markers of inflammation that reflect systemic inflammation. One is an ESR, or a sedimentation rate. The other is a CRP, or C-reactive protein. And there are many things that can cause those markers to be elevated. One of them is active rheumatoid arthritis. There are countless other, infections, viral infection, malignancy. There are just many, many things. It's a very non-specific marker in the blood. So I would not treat a number or consider a number only. I know that in some of the definitions of remission, those numbers do have to be in the normal range or low, but I don't think it's the only thing we have to look at.
How else would you gauge remission for someone then?
Yeah, so certainly the patient global assessment of disease activity. So when we ask them, in all the ways in which rheumatoid arthritis affects you over the past week, how would you say you're doing? Very well or not very well? So I think that's important to have that be, someone's doing very well on their patient global. We certainly have the 28 tender and swollen joint count. So for me, I do want to see that there are, I can't detect active synovitis, or we don't have tender joints on exam. Certainly there are other things beyond rheumatoid arthritis that can cause a tender joint. So if you have osteoarthritis changes, for instance, or other things that are painful. So, it's really trying to do the best job we can to make sure that these symptoms or signs on exam are from rheumatoid arthritis, which can sometimes be tricky.
That is very true. Now, this is a very popular question among patients, but does lifestyle play a role in remission, including diet?
Wow. I think, does lifestyle play a role in health? And I would say yes. So I think, how we are able to, manage our stress, to eat nutritious foods, to move our bodies, to be physically active, to get enough sleep. I do think all of those things collectively impact our health, and therefore, may influence our ability to achieve remission. So this is where I think having a global perspective on health in general is really important. Can someone use just diet to get themselves into remission? I don't know. I think some people would say yes, they could. I think, I'm a very Western trained physician, and so I'm going to say that we may need the help of disease modifying anti-rheumatic drugs or a lot of our RA medications to help people
That is,
achieve that as well. Yeah.
yeah, that is definitely true. Now, how long does remission typically last, and what are some of the causes that may cause somebody to fall out of remission?
So in an ideal world, remission would last for the rest of one's life, right? That would be the goal, that we get people into remission. And I think the early aggressive, and when I say aggressive, treating to target approach, where I think we've made a lot of progress in the last 20, 25 years, that if we can identify, diagnose very early on, start therapy, and get people into remission early, is really important, and that we have a better chance of maintaining that remission over time if we can get people into remission early. So that's the ideal scenario. And up to a third of people may respond to methotrexate alone if that's optimized. So getting up to the required dose, changing from oral to subcutaneous administration, as well as attending to all the other things with regard to health. So what are the things that can, bump someone out of remission? Certainly if someone has to come off therapy for any reason, if they have an infection, if they're coming up against a surgery, certainly I've seen people who go through stressful periods in their lives. So if there's a major upheaval, a loss of a job, a loss of a loved one, any significant stressor that may just impact their ability to take care of themselves can certainly, put people out of remission. So I think those are just some examples.
Did the COVID
And therapy can fail people too, right? So, things can work for a while, and then for whatever reason, it's been a year and a half on a biologic, done beautifully, and then all of a sudden, more stiffness, more painful swollen joints, and the therapy fails them.
That is so true. Have you noticed a uptick in people coming out of remission since the pandemic at all? That was quite stressful on inflammatory arthritis patients for sure.
Yeah, it's I don't have exact numbers for the patients that I see, but certainly, and there are multiple reasons. Again, having an infection, stopping therapy, disruptions in getting the therapy, fear of that the therapy was going to put them at higher risk for poor outcomes with COVID. So there are many reasons. So I don't have exact numbers to say, yes, there are more people that are not in remission, in my own practice, but I can certainly see some pattern to that.
Now, living with rheumatoid arthritis, I certainly know that when you have one chronic illness, you have chronic illnesses following after that. What comorbidities get in the way of somebody reaching remission?
So that's a great question. I think that we definitely see higher rates of depression and anxiety in people with rheumatoid arthritis. I think there are studies to show that the patients with those comorbid conditions do have a harder time achieving that lower patient global, for instance, or may have a harder time improving their function or sleep, or reduction in tender joint counts. Certainly we can see comorbid hypothyroidism. So if we see another autoimmune condition that goes along, they can march in pairs. And so that's another condition I think that certainly affects, I've seen, joints and joint pain. I know that, and I don't, in terms of having diabetes or just other things where it just the burden of treatment and taking care of oneself becomes much greater when you have more than one chronic condition. And I think that all of the steps that are needed in terms of attending appointments, getting monitoring labs, making sure one takes all their medications, et cetera, I think that becomes harder and harder as we add on other chronic conditions. And so I think, all of those things can make it more difficult.
Absolutely. Can you still have pain, fatigue, or cognitive dysfunction and be in remission, and why?
So there are definitely studies that show this, that there is, despite achieving remission by, the definitions that are out there, people continue to have significant impacts on their quality of life in terms of pain, in terms of poor sleep, in terms of cognitive function or mood. And I think that's where, as rheumatologists, it's a challenge. We feel like we've done everything that we can with our therapies. And this is where I think having an interprofessional team for people with rheumatoid arthritis. So, and, making sure that we are calling on our other team members to help support patients to maybe look at integrative treatments in terms of mind-body exercise, physical activity, attending to one's diet, mood, sleep, all of these things, which I think are, they influence, I think people's experience in their daily lives. And I think this is where having just expanding our team is important going forward, and knowing that physical activity can improve fatigue. And I think fatigue is such a tough symptom, and it really impacts people. But I think we have to think broadly about how to address that and allow space to talk about it.
Yes, definitely. As somebody living with RA, fatigue is my number one most difficult symptom to have to manage, because there isn't as much for it as there is for pain. Now, you did touch a little bit on this one already, but can you stop medication if you reach remission?
Oh boy. So that's like $1 million question, right? So what I generally say is that, rheumatoid arthritis is a chronic condition that we do not have a cure for. I think quality indicators would say that if you have rheumatoid arthritis, you should be on a disease-modifying anti-rheumatic drug, or that could be, one of the synthetic therapies that we have that doesn't carry maybe as many potential side effects or need for monitoring. And I think this is a conversation that each patient has to have with their clinician, which is, I've been in remission, and I would love to see people in remission for 18 months or longer before entertaining the discussion of coming off of therapy. We used to see the natural progression of RA off of therapy when we didn't have as many options and things like that. And so, there's this concept of burned out RA, or where, the joints do maybe quiet and there isn't any inflammation any longer. So, but I think that's a really individualized conversation between a patient and a clinician. And it's a hard thing to say, yeah, you can come off completely. And so that's where, I generally want to see people in sustained remission for a pretty decent amount of time before having that conversation.
A really good point to bring up, and it's so important that it is a conversation that you have to have with your rheumatologist, and it's so individualized. That's important. You also just touched a little bit on this one, but are remission rates increasing, and why?
So great question. In terms of like a national sample, again, I'm not gonna be able to cite a study. I would say anecdotally, I have definitely seen better control of rheumatoid arthritis in terms of being in low disease activity and or remission. I think I mentioned the strategies in terms of treating to target, treating aggressive, treating early, and that's, I think, changed the landscape a little bit. I think the number of therapies that we have, again, we have many more options for people now than we did 25 years ago. So I know that that's contributing likely to maybe more people being in remission. And certainly, the waiting rooms full of people in wheelchairs or having significant deformities. I think we are seeing less and less of that as time goes on.
Yes, that's actually something that I've been hearing quite a bit with different rheumatologists and people who care for different forms of arthritis. And I think it's wonderful news. uh,
Yes.
okay, so now here's a loaded one. Who has a higher chance of remission, seropositive or seronegative?
So I think, historically it would be a seronegative. Um, Someone who is seronegative, they tend to have a better prognosis in terms of fewer extraarticular manifestations of RA, so fewer nodules or lung involvement, and just sort of tend to have less severe disease. So I would probably opt to say people who are seronegative. And then of those who are seropositive, there are, you can be high positive versus low positive. So again, people who may be low positive or only rheumatoid factor and not CCP positive, people who are not double seropositive may also have a better prognosis. But yeah, lower positivity or seronegative, I would say tend to do better.
I think it's really important to know as a patient that there is a difference between seropositive, seronegative, and mild to moderate to severe disease activity. Because what works for one may not work for another, and that is a clear indicator why. So my next question is remission more common in males or females?
That is a question I do not know the answer to. So I actually don't know if there is data out there, and I probably should know this, but I cannot answer that without looking at the literature. It's a great question, and I don't know.
I'm glad to stump you in a question. It was that I was thinking about. So that's okay. If anybody's watching that does research, there you go. There's the topic. Okay, and I've got another similar one. Is remission more common in younger or older adults or children?
Yeah, I think this is an indirect way to answer that, but I would say that it may come down to disease duration. So we may see higher rates of remission or low disease activity in people with shorter disease duration. And that being said, those, we're maybe identifying those people earlier and treating them aggressively. And so they may have less years with rheumatoid arthritis without the number of options that we have. So that's a bit of a dodge. So and I can't comment really on a pediatric population because I'm an adult rheumatologist, so I really don't feel like I could answer that fairly.
All right, so you've touched base on this a few times, and I think as somebody who didn't get diagnosed early on with rheumatoid arthritis, and also the way insurance has it that we have to go through our different drugs. You have to start with the cheaper ones, see if you fail those, and then you get on to the gold stuff, as I like to call it, for people who have various obvious seropositive, moderate to severe rheumatoid arthritis. That effective and early diagnosis is so important to us, but some of us never had that chance. So is that possible for people who have had a delayed diagnosis and have more severe rheumatoid arthritis? Is remission still possible for them?
I would say it's still possible, but it is harder to achieve remission. And there are studies that look at the time at which you start treatment and the chances of getting into remission and staying in remission. And this goes back to, studies even in the early, maybe 15 years ago that showed early diagnosis, early aggressive treatment, you can get into remission earlier and stay there. And so the longer it goes before you're diagnosed, treated and gotten into, and then it's just harder to get into low disease activity remission and maintain that as time goes on. So that's why really educating primary care clinicians about identifying inflammatory arthritis and even making them perhaps more comfortable with starting a medication, like, but starting sort of the cornerstone of treatment for RA while you're waiting to get someone in to see. I think that is going to be a potential path forward if we can really, elevate how we, share knowledge with primary care to make it, easier for diagnosing RA and the emphasizing the importance of early aggressive treatment with a DMARD. And so, it is harder to achieve remission. I think the longer one has not been treated.
Mm-hmm. Now, you've touched base on which comorbidities may prevent somebody for remission, but are there other types of barriers that may prevent somebody from reaching remission?
Yeah, I mean, I think, access to a rheumatologist. Ideally, you'd want to see a patient every 12 weeks at minimum to see what is their disease activity, adjust therapy, repeatedly, with frequency to get them into remission. So I think if there is an issue in terms of accessing a rheumatologist, which we know there's a workforce shortage that we face, certainly that's a barrier. If there are challenges with access to therapy, as you've alluded to, are there barriers from insurance companies or things like that that prolong the time, even though we know this is the one you need, but it's going to take, however long to get approval and things fall through the cracks, et cetera, et cetera. So, I think those are important barriers at a system level. I think if at a patient clinician level, if there's not good conversation, if there's not trust, and if patient doesn't feel confident in the decision that was discussed, they may pause and say, I'm not really sure, and may not feel confident bringing that up with the clinician and take the prescription home and never fill it. So I think making sure that we as clinicians are eliciting concerns, beliefs around medications, barriers at the patient level, like maybe someone doesn't have a refrigerator to store their biologic in. And so that's just not an option at all, but it's not discussed. So I think any sort of barriers around, at the patient level, at the patient clinician level, at the system level, they need to be really, we need good communication and conversations to make sure that we're identifying those things and having really like non-judgmental conversations about, I want you to get into remission. We need to work together to figure that out.
Absolutely. I 100% agree. And that is such a perfect lead into the last two questions I have for you. What are some important questions patients can ask their rheumatologist around remission?
I mean, I think a lot of the ones you've just asked me, sort of what is it? What are my chances? How does the clinician define it? And, are there, barriers that the clinician may see for that individual person to achieve remission? So I think, a lot of what you've asked me is really important. What are, and having that conversation about, well, am I seropositive or am I seronegative? A lot of patients may not know that. Do I have changes on my x-rays that are concerning? What else can I do beyond taking these medications? What else can I do? It's, and we've talked about, should I be seeing a physical therapist, an occupational therapist, other interprofessional team members to help me achieve remission?
Absolutely. And thank you so much for the wealth of knowledge you've already given us, but I just have one last question before I let you go. Is there anything else that you feel is important for patients to know?
Yeah, I think, I think your experience and your opening up, these conversations with different clinicians around the world is so important. I think that I would just say never feel like you can't ask a question. And people want to know, they want answers from their clinicians, their rheumatology clinicians. And I think that we should all feel empowered to write those questions down before we go and see, go to the clinic visit and try to have our questions addressed. And I do think it should come from the trained, clinicians in rheumatology. So I would just encourage people to feel empowered to ask questions and to be involved in their care.
Absolutely. Well, thank you so much for such an insightful conversation. It has been perfect. You've captured so many different aspects of what it's like to go through trying to reach remission and everything that we need to do. I know that patients from newer diagnosis to long-term diagnosis are going to find a lot of information in what you have just said. So thank you so much for joining us today.
Well, thank you for having me. It's been great to